Aortic regurgitation is a not so common valvular disease, at least not as common as aortic stenosis and mitral regurgitation, yet it is an important valvular disease which carries significant morbidity and mortality. My name is Hector Michelena. I'm a professor of medicine and the chair of research and innovation for structural heart disease and echocardiography at the Mayo Clinic, Rochester. And I'm very happy to share with you a little bit of our findings with an article that will be published in the August issue of Mayo Clinic Proceedings called Sex Differences in Outcomes of Patients with Chronic Aortic Regurgitation, Closing the Mortality Gap. And it is important to know that aortic regurgitation represents a pressure and volume overload. And because there's a pressure overload involved, surgery is almost always better. So even people that are referred for aortic surgery for regurgitation very late with low ejection fraction, they will do very poor without surgery. It is also very important to know that significant aortic regurgitation includes severities 3+ and 4, which would be more than or equal to moderate to severe. That aortic regurgitation is more common in men, about 75 to 80% are men, and that we and others have showed that current surgical triggers of class 1, which are decreased ejection fraction and symptoms, are associated with worse survival for these patients. So you don't want your patient with aortic regurgitation to achieve significant symptoms or a decrease in ejection fraction, because their outcome, even with surgery, is then going to be compromised. Therefore, we have come up, many cardiologists over a long time, with markers that can identify asymptomatic patients that are at high risk so that they can receive surgery. And one of these markers is the end-systolic diameter. Because the end-systolic diameter of the left ventricle occurs at end systole, that's the moment where elastance is made, and that's the moment where contractility can be calculated in a pressure volume loop. Therefore, end-systolic diameter is used as a poor man's indication or as an echocardiographer's indication of left ventricular contractility. That being said, in 1996, there was a publication in Circulation from this institution showing that the post-operative survival of severe aortic regurgitation, comparing men versus women, was in favor of men. In other words, men were surviving much more than women. And there was a clue into why this was happening. Basically, women were being referred much more commonly after achieving class 3 to 4 symptoms than men. And the other thing is that women, because they are of smaller size, did not achieve the end-systolic absolute dimension of 55 millimeters, which was according to guidelines at those years. Now, if this is a 1996 article, it examined a population in the 1980s. Therefore, it was recommended to index the end-systolic diameter, and it became an index for body surface area. And because we're all different sizes and women are smaller, a cutoff of 25 millimeters per meter square was employed. Now, we're in 2021, and here is where the new study comes in. So what we did is we wanted to see what has happened in all these years, particularly in light of we and others showing that a cutoff of 20 millimeters per meter square of end-systolic diameter is much more sensitive to predict death in asymptomatic patients and symptomatic patients than the current cutoff of the guidelines, which is 25. So we examined a contemporary clinical cohort from 2004 to 2019. This was a retrospective study through our ECHO database, and it's from a single institution, and therefore it may not be generalizable for all situations. In addition, the population here in Minnesota and the tertiary referral population is mostly white of European descent. And we were not able to study other sex differences, such as capability of access to healthcare, knowledge of the person's own disease, and sex discrimination in the medical field. These things were not able to be examined. So we identified 189 women in this decade or so versus 883 men. Women were a little older than men. And again, and unfortunately, they had more advanced symptoms at presentation and had larger left ventricular end-systolic index than men at presentation. However, even though the survival of women versus the US population was again compromised in the overall cohort versus the survival of men compared to US population, which was the same, we found interesting things. We found that the post-operative, post-aortic valve replacement or repair, survival in women was exactly the same as men, which is a tremendous advance in the mortality gap, at least as shown by that prior study in 1996, showing that the post-operative survival was severely impaired in women. In addition, when we compare those two papers, our current with the 1996, women are being referred earlier when you compare the sizes of left ventricle and the amount of symptoms, yet it's still not enough. There's still a remaining gap, which gives women a 1.3-fold increased relative risk of death as compared to the population, while men don't have it. But we found another interesting thing, which is a significant proportion, more than 60% of women who were asymptomatic had a left ventricular end-systolic diameter index of more than 20 millimeters per meter square. Therefore, we concluded that in contemporary practice, women with aortic regurgitation continue to exhibit overall survival penalty, which, by the way, was not related to female sex in multivariate analysis, but related to late referral markers, including advanced symptoms, larger left ventricular end-systolic diameter, and also female sex was a marker or was associated independently with less referral to aortic valve surgery. We found a significant proportion of asymptomatic women who had left ventricular end-systolic indices more than 20 millimeters per meter square. Therefore, that represents a great window to identify women at an early stage for early referral for surgery, so we can close the mortality gap once and for all.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.